Okay, so hello, and we're going to go ahead and get started. Welcome to our webinar today. We're excited that you've decided to join us, and we hope that this is going to be informative for you. We're excited to share a webinar, What You Need to Know About the 2018 Quality Payment Program Proposed Rule and the Future of Value-Based Care. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for Itentive. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. We'll send out a copy of the slides and recording within the next week. Next, for those of you who aren't familiar with Itentive, I wanted to share a bit of who we are with you. We specialize specifically in next-gen healthcare. We're passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything next-gen. And we also have two add-on productivity solutions for next-gen, ChartGuard and Refund Manager. Speaking of ChartGuard, I'm excited to announce our upcoming demo of it on September 19th. ChartGuard enables you to print, view, or electronically access your patient charts and practices appointment books, even when your EHR system fails or your network is down. It integrates in with your current next-gen healthcare system for an easy user experience, and it automatically generates customized printable copies of your clinical charts for the next several days, along with copies of your appointment book, and refreshes every night. You can register for that on our website in the Events and Education section, or let me know in the questions area, and I'd be happy to register you. Okay, so back to today's webinar on the QPP proposed rule. At the end of the presentation, we're going to open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenter for today. Lindsay Lanning is Healthcare Compliance Consultant at Itentive. So Lindsay, the webinar is all yours. Feel free to get started when you're ready.
Great, thank you, Chelsea. Well, hi everyone, and thank you for joining us today for our webinar, What You Need to Know About the 2018 QPP Proposed Rule and the Future of Value-Based Care. Now, I'm going to ask all of you this. Is anyone else feeling absolutely overwhelmed and honestly a bit concerned by the constant release of proposed rules that could impact your practice? Since I can't see any of you out there, I'm assuming most of you on the call are either shaking your head yes or showing some form of agreement. Well, I do have two pieces of good news for you. Number one, you're not alone in feeling this way. And then number two, you're attending the right webinar to help you figure this all out. For the next hour, we plan on sorting through all the legislative jargon to find out what actually applies to you. So while this webinar will not recap the requirements under either MIPS or the APM tracks under MACRA, it will analyze current program policies compared to the proposed changes for 2018 broken down by topic. We do have a few important updates to address for 2017 reporting, but then the rest will primarily focus on the 2018 Quality Payment Program proposed rule and how it will affect you in your practice. And we will do this by exploring each of the major changes proposed by the rule. And then at the end, we're also going to highlight other important pieces of legislation that have either recently been finalized or are on our must-watch list for rules to keep track of. So our goal really is to hone in on the specifics that are important to our provider partners and remove all the unnecessary legal stuff surrounding it. Now, I'm not going to lie, it's still a ton of information even with the slimmed down version, so bear with me. I actually jokingly told Chelsea today I'm equating it to an information snowball fight where I have about 62 arms and just keep catapulting information at you. But I promise I will make this as pain-free as possible. So our first housekeeping item for 2017 MIPS reporting is the hardship exception. Clinicians can now submit a QPP hardship exception application, and it's actually available on the QPP website. MIPS eligible clinicians and groups would qualify for a re-weighting of their advancing care information performance category score to 0. And you can submit the application for one of the following reasons: either insufficient internet connectivity, extreme and uncontrollable circumstances, or lack of control over the availability of cert. These reasons are the same ones that we saw in previous years. This isn't anything new. The application actually looks very similar. Now, there are some MIPS eligible clinicians who are considered special status. those clinicians will actually have their ACI category automatically reweighted to 0, and they don't have to submit a hardship application. If you don't fall under that category and you are going to submit an application, just a few things to keep in mind to make the process go a bit smoother. Make sure you have your tax ID number, your TIN on file. Make sure you have your NPIs ready for any providers you're applying for. You need to make sure you have some solid contact information. You enter in the email address correctly for someone who is going to be reliable in tracking the application. And then you're going to need to select one of the hardship categories I mentioned earlier. So once an application is submitted, you're actually going to receive a confirmation email. And then you can go back and check and see if your application is either pending, approved, or dismissed. And applications are being processed on a rolling basis, so make sure you keep good track of those. And lastly, eligible professionals who are first-time participants in the Medicare EHR incentive program in 2017 are also going to be eligible to apply for a one-time hardship exception, and that's going to be due by October 1st of this year. Our second and final item to address for 2017 performance year is that special status calculation. And I already mentioned the fact that CMS stated these clinicians who are considered special status automatically get their ACI reweighted to 0 and don't need to submit an application. For 2017, the special status clinicians include hospital-based MIPS eligible clinicians, any PAs, NPs, CRNAs, and CNSs, non-patient-facing clinicians, clinicians in rural or health professional shortage areas, and lastly, ambulatory surgical center-based MIPS eligible clinicians. And this is still proposed, it's not finalized yet. CMS explained basically the special status is going to be determined by Medicare Part B claims analysis. And you can actually identify if you have special status by going on and using that QPP lookup tool on their website. Keep in mind this tool is actually supposed to be updated again closer to the end of this year. And they're going to update that with the second eligibility snapshot data. And that's actually taken from September last year to August 2017, so tomorrow. So look for that update and go ahead and check your status on the QPP lookup tool later this year. Now let's switch gears and start thinking a little bit farther ahead into the future to next year's quality reporting program, because if we can believe it or not, 2018 is only 4 months away. As this new program moves into its second year, CMS has been abundantly clear it wants to ensure that there are meaningful measurements being taken that have the opportunity for improved patient outcomes while still minimizing provider burden. And you can see both of these concepts listed as main goals of the program, along with spending wisely and being fair and transparent. These goals also align with the triple aim that we've seen for many years now. Really, these ideas keep continuing forward in these value-based programs. CMS actually came out with this statement earlier this year. I'm not going to read it to you guys. You can see it on your screen. But basically, it reinforces this idea of transparency and reducing the clinician burden. They affirm the goal of this proposed rule is to improve Medicare by actually helping doctors and clinicians concentrate on caring for their patients rather than filling out paperwork to meet these proposed rules. So with this statement fresh in our minds, let's look at the considerations CMS has identified they had in mind when constructing this proposed rule. We see right off the bat the top 2 items listed are improved beneficiary outcomes and reduce clinician burden, which were taken straight from those program goals. But then we see some more long-term goals that are shaping the program. And they are increased adoption of advanced APM, so again, moving more towards that value-based care model, and also maximizing participation. Improve data and information sharing. Ensure operational excellence in program implementation. And then deliver IT system capabilities that meet the needs of the users. Now that we have a grasp on the goals and considerations that make up the foundation of what this program was built on, let's start by looking at the 2018 Year 2 changes put forth by the proposed rule under the MIPS track specifically. The Some trends and highlights to keep in mind while we go through each of these proposals include a gradual increase in requirements. CMS plans on gradually increasing requirements to avoid a payment cut and earn a bonus payment in MIPS. And with that comes the opportunity for an increase in payment adjustments, both positive and negative. So it's actually expected at 5% this year. Or excuse me, in 2018, 2017, it's 4%. Next, you'll see an effort to increase reporting flexibility for clinicians and groups for all of the performance categories. We will also see a lot of changes that will impact small practices and provide relief for them. One of these changes actually is the increase in the low volume threshold. The agency proposes to substantially increase the low volume threshold, which actually excludes approximately 63% of clinicians from MIPS in 2018. And then finally, cost measures are going to be excluded from the MIPS final score. So as we go through each proposed update next under the MIPS track, you should be able to identify how each one fits into one of these trends. All right, first things first, who participates in MIPS for 2018? Good news here, there has been no change in the types of clinicians eligible to participate in 2018. These will still include physicians, PAs, NPs, CNSs, and CRNAs. However, this list may very well be expanded in 2019, and that's the plan right now. The exclusions are also the same for 2018. They include eligible clinicians new to Medicare, any clinician below the low volume threshold, and any clinician significantly participating in an advanced APM. Highlighting one of those exceptions to participate, one of the biggest, if not the biggest, change found in the proposed rule is the increase in the low volume threshold. CMS proposes to increase the threshold that excludes certain ECs and groups. The current threshold is actually $30,000 or less in Medicare Part B charges, or 100 or fewer Medicare Part B beneficiaries. For 2018, CMS proposes to exclude any ECs or groups that bill $90,000 or less in Medicare Part B charges, or see 200 or fewer Medicare beneficiaries. The agency actually projects over 585,000 clinicians would fall below this threshold and be excluded. That's over 500,000. Additionally, CMS is proposing that in 2019, there be an opt-in process for excluded eligible clinicians and groups, so they can actually voluntarily participate in MIPS and receive payment adjustments. But again, that's 2019. So the hope is that this will actually balance the participation burden and help small practices with this complex program. So some of you on the call that have used the lookup tool on the QPP website, you've logged on, you've searched your NPI and confirmed you're above the 2017 threshold and you have to report under MIPS, you may actually be exempt next year. But in 2019, you can voluntarily choose to opt in if you think your numbers are good enough to get a positive adjustment, because honestly, why leave free money on the table if you can have access to it? Next, we have the submission methods. This year for 2017 reporting, you can only use one submission method per category. For instance, you may be hearing practices deciding between EHR and registry for the quality category. They may be sitting down, figuring out which submission method would be best for them based on different benchmarks or decile breaks. Well, next year, CMS is proposing to allow individuals or groups submit measures through multiple submission methods within a category. This is huge because it means you can literally pick and choose single measures to report using different methods. For example, in the quality category, if we go back to that again, I could choose to submit 4 of my measures via registry because I sat down and I looked at the benchmarks, and that submission method gave me the most points for those 4 measures. Whereas the other 2 measures that I still needed to submit had a better score using the EHR submission method. So I could now report 4 measures via registry and 2 via EHR under the same category. There are no changes in submission mechanisms available. This is just adding more flexibility to reporting to allow clinicians to get the most number of points toward their score out of their data. So again, just adding in that flexibility. moving on to the quality category and its specific category changes, CMS would continue to require eligible clinicians and groups to report 6 measures, and that needs to include 1 outcome or high priority measure. And they would evaluate each measure against a benchmark to determine a score up to 10 points. CMS proposes to continue requiring reporting on at least 50% of applicable patient encounters. Each measure that meets the 50% data completeness threshold would continue to score a minimum of 3 points. However, measures that fail data completeness will receive 1 point instead of 3. Unless you're a small practice, then you still receive the 3 points. And then just a heads up, in year 3 or 2019, CMS is looking to increase that data completeness threshold to 60% instead of 50. And then we have the weight to the final score. CMS is going to retain a weight of 60% in the 2018 performance year instead of lowering it to 50% as previously planned. And they're also going to maintain the 30% weight in 2019. So it'll just be a steeper fall in weight from 60 to 30% versus having that middle step in there from 50 to 30%. And then lastly, for quality, we will look at how scoring is changing. We already mentioned that measures which don't meet the data completeness requirements will no longer get a floor of 3 points. Instead, they're only going to see 1 point, unless you're a small practice. But CMS is being nice. They're keeping the 3-point floor for measures that don't have a benchmark or don't meet that 20 case minimum. And then I think everyone will be happy to hear the bonuses are still in place for additional high priority or outcome measures that are reported, and also for the end-to-end electronic reporting. New this year for the quality category is a policy on the life cycle of topped-out measures. CMS is actually proposing to cap a subset of 6 topped-out measures at 6 points. So through future rulemaking, the agency would remove these measures from the MIPS measure list after they were deemed topped out for 3 consecutive years. And CMS considers a measure topped out essentially if the performance is so high and unvarying that distinctions and improvement can't be made. So here's the current list of topped-out measures identified by CMS. Just be aware, if you're planning to report on any of these this year, you may not be eligible to receive the full 10 points at some point in the future. You're fine for this year. Just if this policy is finalized, these measures would only earn you 6 points, even if you have 100% performance, if they're identified 3 years in a row. So this is the first year they're being identified. You still do have 2 years. It's just really meant to kind of point out how important it is to start balance tracking measures. And you can do that by looking at those that are identified as high priority or those that have lower benchmarks for higher points, trying to report on those, but also still relying on those really good, solid performance measures, such as these topped out ones, to ensure success in the program both now, but also in the future. Looking at another new policy in 2018, CMS is trying to add in the idea of improvement scoring. So this rewards improvement in performance for a MIPS EC for a current performance period compared to the prior performance period. So for the quality category, improvement scoring will be based on the rate of improvement. So the higher the improvement results, the more points you get. And it will be measured at the performance category level, not the measure level. And ECs can see up to 10 percentage points available to them for that category. So CMS has stated in the past it wanted to reward improvement, not just hitting a standard or a threshold, and they're finally making this a reality. Some of you may actually be wondering, wait a minute, does this mean I have to report the same 6 measures every year? You just told me I had to start balance tracking. Yeah, no, you don't have to report the same previous measures. This improvement scoring for quality is scored at the category level. So instead of tracking improvement on a specific measure, CMS is tracking and rewarding improvement on your total category score. So for quality, it's out of 60 points. Let's say this year you score a 40 out of a possible 60 points, and next year you score 50. That's going to show improvement. So let me reiterate, nope, you're not required to submit the same measures each year to get these improvement points. you do have this same improvement scoring opportunity for the cost category as well. So for the cost category, improvement scoring will actually be based on statistically significant changes at the measure level. These measures don't change, so CMS can do this. So this measure level versus category level improvement is the major difference between the two scoring policies. Although just keep in mind, no improvement percentage points will be available for cost for 2018 because the weight of the cost category is still proposed to be 0. Now, if we move on to the cost category, I mentioned that the cost measures would remain weighted at 0% in 2018, and they would continue to be excluded from the final MIPS score. Although the measures don't count, CMS would continue to evaluate cost data and actually include the results in MIPS feedback reports. So as we just went over, CMS does propose to calculate that improvement scoring. Of course, why not make an already complex program more confusing? CMS is using that different methodology than the one proposed for measuring quality improvement. Cost is much more stringent on improvement because it will depend on the measure level, not the category. So CMS does wish to maintain a weight of 30% in 2021 MIPS payment year and beyond, so in 2019. And since the feedback reports are still happening, clients should expect a supplemental QRUR, if anyone remembers those from the value-based modifier days. This should help you identify what you would need to do to be ready by 2019. So these QRUR reports, they're showing you your performance. They won't actually contribute to your score. You won't see any penalties because of them, but they're going to be a great resource moving forward. Essentially, this cost category is going to mean more care coordination once it starts counting toward your final score. It takes more than, I think, any other category, which the other categories depend heavily on EHR documentation. This is going to really depend on truly coordinating care while lowering spending and still providing quality care. So the third category under MIPS is the improvement activities category. This category, this is the new one. It would remain largely the same in 2018. CMS would continue scoring improvement activities out of 40 points, which clinicians will still achieve by reporting or attesting up to 4 activities, just by having a yes designation for those. The agency is proposing to add to and update the inventory of activities. They're actually looking to add about 15 to 16 new IAs. And one of those is actually going to qualify. The appropriate use criteria will be added as well in this inventory, if a lot of you have been hearing that lately on the next gen side of things. If we look at the proposals affecting improvement activity scoring, we're going to see no change in the scoring policy for APMs or MIPS APMs. We will see the continuation of designating activities that also qualify for an advancing care information bonus, as well as continuing to allow simple attestation of improvement activities, so just that yes designation. However, for group reporting, currently, only one MIPS eligible clinician and an entire TIN must perform the improvement activity for that entire TIN to receive credit. CMS isn't recommending a change for this policy in 2018, but they are seeking comment on a threshold for the future. So just be aware that this may be on the horizon, that just having one clinician do an improvement activity may not suffice in future years. Now, one thing that has changed under this category are clarifications regarding PCMH status and scoring. CMS will continue to give certified patient-centered medical homes, or PCMHs, or comparable specialty medical homes the maximum improvement activity score. The agency also proposes to expand the definition of a PCMH by including CPC Plus participants, and they clarified that a recognized PCMH is equivalent to a certified PCMH. There was this huge debacle over vocabulary for some reason in 2017. There's really no reason for it. CMS just put their foot down and clarified they're the same. Don't get too caught up on the wording here. CMS also plans to require at least 50% of practice sites within one TIN be recognized as a PCMH for that TIN to receive full credit in this category. This is an increase from the current requirement. Currently, only one practice under the entire TIN needs to qualify for the whole TIN to be seen as a PCMH. That's actually moved up to 50% of practice sites. So you will notice there are a few different places in this proposed rule that aren't necessarily changes, but clarifications on points of confusion that have surfaced during the 2017 performance year. I think CMS has done a good job of making slight modifications to either better clarify requirements, such as that vocab misunderstanding, or reshape them to better represent the goal of the program, such as that increase from one practice site to 50% of practice sites under one TIN for this PCMH credit. And lastly, the final fourth performance category under MIPS, advancing care information, aka meaningful use, with a new name and some new rules, as I like to call it. First off, we all know the ACI category would continue to require ECs and groups to report on 4 mandatory base measures. Those are going to be your security risk analysis, electronic access, e-prescribing, and health information exchange. And if you report on those, you can avoid a score of 0 and receive a 50% in the ACI base score. Now, ECs and groups would also continue to select 7 optional performance measures, and that would contribute the other 50% of your ACI performance score. The agency is proposing a new exclusion for e-prescribing and health information exchange measures. So to qualify for these exclusions, an eligible clinician must write fewer than 100 permissible prescriptions, or transfer a patient to another setting, or refer a patient fewer than 100 times during the performance period. Sound familiar? These are the exclusions that were in place for both measures under the Meaningful Use program. CMS received a ton of complaints by eliminating these exclusions for 2017 reporting. In my mind, it's almost like they were so part of the Meaningful Use program, they just forgot to include them in the rules. So for 2017, clinicians are facing a lot of issues with this. Moving ahead, especially since these are part of the base score, so if you are unable to claim these exclusions and you can't get over 1 in the numerator, that means you're receiving 0 points in this whole category. So definitely an improvement on CMS's part. Now, if you're still trying to process the information, that works too, but if you're already jumping ahead and you might be asking yourself, how would this proposed exclusion for the HIE measure work since it's part of both the base score and the performance score? Well, CMS confirmed that the exclusion would basically enable you to fill the base score, and then you would get a 0 for the measure and the performance score. So it would allow you to get that full 50% for the base score, but then wouldn't count towards your performance score. Better than nothing. And then another proposal that will have a large impact on providers is allowing clinicians to use either 2014 or 2015 certified EHR technology for 2018. And basically, you can use a combination of either. However, they are providing a bonus for the use of 2015 cert. I mentioned earlier that CMS is proposing additional improvement activities that would qualify for an ACI bonus, including consultation of appropriate use criteria, or AUC, through a clinical decision support mechanism for any advanced diagnostic imaging orders. So for any next-gen users on the call, we have been hearing a lot about AUC lately. It was supposed to be mandatory starting in 2018, but it's been delayed. So if you do start earlier than required, you will see some perks. CMS also proposed to expand options beyond the one immunization registry reporting measure for 10% toward the performance score. So you can actually report to a different public health registry that applies to the scope of your practice, or you can report on a combination of public health registries. Just a heads up, if you're trying to also go for that 5% bonus for reporting to additional registries, you're going to have to report to different public health registries or agencies than those you use to earn the performance score. Continuing on under the same category, yes, you'll notice this category was extensively reviewed and definitely has the most proposed changes. There's the addition of the new retroactive exception for any clinician whose EHR was decertified. There would also be a hardship exception for our small practices. Now, this is huge and could potentially affect a lot of you on the call. Small practices, which are defined as 15 or fewer clinicians that face barriers to meeting the advancing care information category, could claim a hardship. For these practices, the ACI component of MIPS would be reweighted to 0, and then the 25% category weight would actually just be reallocated to the quality category. Meaning, if you have less than 15 clinicians, you could potentially be excused from meaningful use measures completely. And finally, CMS is proposing to extend the deadline to submit the hardship exception application for 2017 and future years from July 1st to December 31st of the performance year. In my opinion, this just makes sense to do. I never understood why it was due on July 1st anyway, so hopefully we'll see an extension in that. In addition, any clinician who furnishes 75% of their services in an ambulatory surgical center, they would also have their ACI score automatically reweighted to 0, and they wouldn't need to apply for that hardship exception. So I mentioned this in the first few slides. This is why it's still proposed. It's in this 2018 QPP proposed rule. So we should see this come out hopefully early first week of November. All right, we made it through all of the MIPS category changes. Are you all still with me? Are your heads spinning yet? Are you ready to just log off? Well, if you are on information overload here, stay with me as we finish out this MIPS program. We're going to look over the performance threshold and also the scoring changes before we head on to the APM changes. Currently, providers just need to score 3 points to avoid a payment adjustment. And then if they have over 70, they're actually eligible for an exceptional performance bonus. Both of these concepts are staying for 2018, but the threshold to avoid a negative payment adjustment is just being raised from 3 points to 15 points. And that exceptional performance threshold is going to actually remain at 70. So this is a pretty small increase from 3 points to 15 points. And essentially, in my mind, it means that pick your pace mentality that's around for this transition year is still in place. So let me give you some examples on how you could achieve 15 points. You could report all your required improvement activities, and that would give you 15 points on the dot. You could meet the advancing care information base score and then submit 1 quality measure, and that would put you over. That would put you at 15.5 points. You could again meet that advancing care information base score and then submit 1 improvement activity. Or you could even just submit 6 quality measures that just meet the data completeness criteria. So you're automatically guaranteed a floor of 3 points per measure. That would put you over 15 points. Again, it's very doable for all clinicians to avoid a penalty again in 2018. And then as we expected, the payment adjustments did increase by 1% from 4 to 5%. If we remember way back to when MACRA and MIPS and this whole program was first released, CMS clarified this is a budget neutral program. So the losers paid the winners, which means this low threshold scores of 3 and 15, there won't be very many losers. I mean, I just gave you guys about 5 different ways you can report the bare minimum in 2018 and still not see a negative adjustment. So without many losers contributing to the pot to pay the winners, we aren't going to see a positive payment adjustment actually reaching 4 or 5%. It's going to be more like 1 or 2% for these first few years. But if you do choose not to report, you will see the negative full 5% payment adjustment in 2018. And really, this table is just helpful reiterating what I talked about with the final score threshold change and the payment adjustment. You can see the change in percentage for 0 points for not reporting, going from 4 to 5%. And then you can see that neutral payment adjustment threshold moved up from 3 points to 15 points. So looking at the final score, everything is pretty much staying the same in regards to reweighting categories for special circumstances. CMS is just adding bonus points and extenuating circumstances to help providers out who are in small practices who see complex patients or who are using that 2015 certified EHR technology. The performance periods for next year will work a bit differently. Providers will need to submit advancing care information and improvement activities for 90 days. That's really what most clinicians are doing this year. But you will need to report quality measures for a full year. CMS stated the reasoning behind a longer reporting period for the quality measures is that they believe a 12-month period will provide more reliable measures and feedback. However, I would stay tuned to see if this is actually finalized because many healthcare organizations, such as MGMA, are criticizing this change right off the bat. And then nothing new here. All the MIPS category data will need to be submitted by March 31st of the following year for 2018 reporting. Now, there have been some new policies added to the quality payment program. One of them is the small practice bonus. I mentioned it a few times, but essentially, if it's finalized, this would adjust the final score of any EC or group who's in a small practice by adding 5 points to their final score. And basically, they get these free 5 points as long as the clinician or group submits data on any performance category. CMS is also considering giving this same bonus to providers who are practicing in a HPSA or health professional shortage or rural area as well. Essentially, I think CMS just sat down and realized small practices would face the most challenges, and they're hoping that this 5-point bonus will not only help them successfully meet MIPS requirements, but also incentivize their participation as well. Another bonus is being proposed for clinicians who treat complex patients. This would apply an adjustment of up to 3 bonus points by adding the average HCC risk score to the final score. So generally, this will add between 1 to 3 points to clinicians based on the medical complexity of the patients they see. CMS also proposes a voluntary facility-based measurement option for clinicians who perform at least 75% of their services in the hospital inpatient or emergency room setting. The facility-based measurement option basically converts a hospital total performance score into a MIPS quality and cost performance category score. The idea here is that this measurement assesses clinicians in the context of the facilities at which they work to better measure their quality, while also aligning MIPS with the hospital value-based purchasing program. So another plus here, and really another effort to help reduce burden for clinicians. All right, so we're done. Just kidding, we're done with going through all the changes on the MIPS side of things, but it was a lot of information. So I have a few summary slides that sum up the main takeaways here for certain topics covered in the rule. The first one briefly is scoring. Just to go through it quickly, ECs and groups would basically be scored in MIPS based on data in 3 categories: quality, advancing care information, and improvement activities. CMS proposes to keep the weight of cost at 0, quality at 60%, ACI at 25%, and improvement activities at 15%. ECs and groups would need to earn at least 15 out of 100 possible points in order to avoid a payment cut up to 5% in 2020. This is an increase from the current threshold of 3 points, but like I said, could be achieved pretty easily by satisfying the requirements of either just one MIPS category or combining subparts of multiple MIPS categories. Any ECs or groups earning more than 15 percentage points would be eligible for a slight bonus, but those earning 70 points or more would earn an additional bonus between 0.5 and 10%. Again, CMS is proposing to add 5 points to the final score of any solo practitioners or group practices under 15 clinicians. CMS would add up to 3 percentage points for any ECs who treat complex patients. And finally, CMS will incorporate MIPS performance improvement in scoring quality performance. Now, in order to even get a score or see a payment adjustment, you need to report data. While all the submission methods stayed the same, there were some changes to the reporting periods. Again, ECs would be required to report a minimum of 90 days for ACI and improvement activities, and then possibly 12 months for quality measure data. In addition, CMS proposes to score measures within a performance category when submitted via multiple mechanisms. Again, we get that quality example here where you can use 2 different reporting mechanisms under one category. Also keep in mind, like I said, industry leaders have been extremely critical of the full year reporting, and they've actually already started to advocate strongly for a reduction in the quality measure reporting period in 2018. And finally, the last summary is on small practices. I put this in here because I feel like a lot of people on the call could be impacted by all of these changes, so this serves as a good one-stop shop to see how this will affect you. Remember, this is for clinicians in a practice of 15 or fewer providers. First off, CMS will no longer require attestation on group size. It will actually be determined for you using claims data. And this claims data will include clinicians that are not MIPS eligible. Significant areas of relief included in the rule for small practices are the ability to apply for a hardship and have their ACI category weighted to 0, an extra 5 bonus points added to their final score, a lower number of improvement activities required, increasing the low volume threshold to exclude more providers, and continue to award 3 points for measures in the quality performance category, even if they don't meet the data completeness requirements. Okay, so we did make it through the MIPS proposed changes for 2018 completely, and there were a lot. There aren't nearly as many proposed changes for the APM track under the QPP, and we're actually only going to highlight a few since the requirements under this track largely depend on the model you're participating in. Whereas MIPS is pretty uniform across the board, APM requirements really do depend on if you're in the Medicare Shared Savings Program, the Next Generation ACO, whatever model you're participating in. Now, there are a few things that are uniform, and those 3 things, in order to be an advanced APM, is that 1, you need to use a certified EHR technology. 2, you need to provide payment for services based on quality measures that are comparable to those in MIPS. And then 3 is you need to be a medical home model, either expanded under the CMMI, or you need to require participants to bear a more than nominal amount of financial risk. So the first change we will look at has to do with that 3rd requirement of nominal amount standard. So under current policy, total potential risk under the APM must be equal to at least either 8% of the average estimated Part A and B revenue of the participating APM entities, or 3% of the expected expenditures an APM entity is responsible for under the APM. What CMS did was extend this 8% standard for 2 additional years instead of increasing it. By extending the flexibility in nominal risk requirements for advanced APMs to 2019 and 2020, they're essentially trying to foster growth for these models and encourage more providers to join. Now, if you look at the medical home model, CMS revised 2 current policies regarding potential risk and a 50 clinician cap. CMS lowered the potential risk by 1% for each year starting in 2018, starts at 2%. This allows the amount of risk to increase more slowly. And then they also removed the 50 clinician cap for round 1 participants in the CPP Plus program. Originally, the medical home standard applied only to APM entities with fewer than 50 clinicians and their parent organizations. However, CMS will allow CPC Plus organizations to be exempt from this rule. The last major change to the APM track is in regards to the QP performance period and determination. So we're all aware of the fact that just because you're participating in an APM doesn't mean you're automatically exempt from MIPS. You need to hit a certain threshold of patients seen through the APM to be considered a QP and reap the benefits. So for the 2018 reporting period, the period that payment or patient threshold calculations are based on has actually been modified for certain advanced APMs. Essentially, for APMs that start or end during the QP performance period, QP threshold scores would be calculated using only the dates that APM entities were able to participate in the APM. And as long as they were able to participate for at least 60 continuous days during that QP performance period. So it sounds confusing, but basically it's just making it easier on clinicians to reach a QP status. And then we also have a slight name change here. The QP performance period stays the same. It's just going to be called the Medicare QP performance period. Just another vocab change. It's to differentiate between the all-payer QP performance period. I just wanted to make everyone aware of that. So to wrap up our review of the QPP proposed rule, we're going to look at the MIPS APM changes. This scoring standard is almost like a middle ground of the MIPS and APM tracks. It offers a special, minimally burdensome way of participating in MIPS for any ECs in APMs who may not have met the requirements to become a QP. So if you don't become a QP and you're still in an APM, you get in this middle ground and you're still subject to MIPS. You also have clinicians who actually meet the requirements to become a partial QP, and they can actually choose to participate in MIPS. So one of the main changes to this scoring standard is focusing on determining participation as well. Right now, if a MIPS clinician is on an APM participation list on at least one of the participation assessment snapshot dates, so those dates are March 31st, June 30th, and August 31st, actually tomorrow, that MIPS clinician will be included in the APM entity, and they will automatically be put under this APM scoring standard if they don't reach QP status. So for 2018, CMS is actually proposing a fourth snapshot date of December 31st to be added. So this would allow participants who joined certain APMs between September 1st and December 31st of the performance year to still benefit from the MIPS APM scoring standard. So before, if you were a clinician for, let's say this year, 2017, and you joined an APM between September 1st and December 31st, you would actually need to report MIPS fully, and you wouldn't see this MIPS APM scoring standard. So this is good news for clinicians. Basically, it allows them to do MIPS APM versus full-on MIPS, and essentially by adding this, they're reducing full exposure to MIPS reporting. And then lastly, the MIPS APM category weights have been altered slightly. In the 2017 rule, CMS finalized different scoring weights for ACO models, so that's the Medicare Shared Savings Program and the next generation ACO models, which were assessed on quality, while other MIPS APMs had quality weighted to 0. So for 2018, CMS is proposing to align weighting across all the MIPS APMs and assess all MIPS APMs on quality. So I included this table. It just does a good job of showing you how these MIPS APMs are aligning in year 2, which essentially just simplifies the scoring standard for participants. So I think it's pretty clear, after analyzing the QPP proposed rule for 2018, for the second year of the program, CMS wants to keep what's working and use stakeholder and clinician feedback to improve policies. They're trying to reduce physician burden and increase participation in these value-based care programs. So what else have they been working on? Well, let's look at a few legislative changes that either occurred recently or are on the horizon and have made our legislation must-watch list. So I did cut these down a little bit, but the first one we're going to look at, just due to time constraints, is actually the 2018 Medicare Physician Fee Schedule. On July 13th, CMS issued this proposed rule, and it would update Medicare payment and policies, and it actually included a 0.5% increase as required by MACRA. It did a few other things. It expanded telehealth coverage and relaxed coding requirements. So providers would no longer need to actually report GT modifiers on claims. They're actually just going to use a place of service code. It also added 2 new G codes for care coordination at RHCs and FQHCs. And then a big one here, it delayed AUC for advanced imaging services until 2019. I did mention this earlier, but essentially this first year, 2018, would be an educational and testing year. So clinicians can consult AUC using a qualified CDSM when ordering imaging services, and then clinicians would report consultation on their Medicare claim. How this would work was that claims denial actually wouldn't happen until 2020. So despite the delay, CMS does expect providers to voluntarily start reporting, and they would actually incentivize early adoption by providing that improvement activities credit under MIPS. This rule also included a hardship for providers for this AUC, and it would actually exempt them if they applied for it. It would automatically exempt a provider who was exempt from ACI, or the Advancing Care Information, for this as well. It also retroactively reduces PQRS and meaningful use reporting requirements. So you used to have to report 9 measures across 3 domains. This actually reduces it to 6 measures with no domain or cross-cutting measure stipulations. In turn, it also reduces value modifier penalties for 2016. First, for providers who fell short of PQRS criteria, the agencies can actually cut penalties in half, from 4% to 2% for groups of 10 or more, and then from 2% to 1% for groups of 9 or fewer EPs. And second, CMS would actually hold harmless any practice who fully satisfied the modified PQRS requirements. So as long as you submitted 6 PQRS measures, you're going to avoid a penalty. And then lastly, it removed the PQRS data from the Physician Compare website. So CMS proposes not to move forward with reporting practice-specific 2016 performance and payment adjustment information. That was going to be viewable to all your patients. And then the last piece of legislation we will look at is the fiscal year 2018 Medicare Hospital IPPS and LTCH prospective payment final rule. And this was actually issued on August 2nd. While this final rule primarily updates Medicare payment and policies when patients are discharged from hospitals, it also finalized changes to the EHR incentive program for 2018. CMS just kind of snuck these in here. And what it does for 2018, CMS is finalizing the modification to the EHR reporting period for new and returning participants attesting to either CMS or Medicaid, from the full year to a minimum of any 90 continuous days. CMS is also finalizing the addition of a new exception from the Medicare payment adjustments for anyone who had their EHR technology decertified. It also finalized an exception to the 2017 and 2018 Medicare ambulatory surgical center-based EPs. And then lastly, CMS is adopting final policies to allow healthcare providers to use either 2014, 2015, or a combination of both certified EHR technology for 2018. So, what do these pieces of legislation tell us about the future of healthcare? Well, clearly healthcare is moving more and more towards value-based care. The transition from volume to value is well underway and honestly shows no signs of stopping, especially with legislative changes such as these. The government really is focusing on lowering healthcare costs and improving quality of care, and they're doing this by linking outcomes to payments and still tracking quality data for providers pretty closely. I think each one of these rules plays a role in tying payments for care delivery to the quality of care, and I think it also rewards providers for efficiency and effectiveness. So if you are uncertain with where your practice stands, not only with the impact of these legislative changes, but with anything related to the health of your practice, let Itentive help you. We can assess your current readiness, provide recommendations, and also implement new processes or procedures. Another way we can help is through our macro support packages. The time really is now. I can't stress this enough to start preparing for MIPS reporting in order to get the highest reimbursement possible. And we can help you by tailoring the support you need, either through our macro fundamentals package, our intermediate package, or our expert package. So if you are wondering what your next step should be, go ahead and visit us at itentive.com. Continue to sign up for our webinars, follow our blog. We also have some free 3-day fixed price on-site consultations, and you can also test drive our products. All right, we have made it to questions. Thank you all for bearing with me through that. I apologize. Our other industry and next-gen expert, Cindy Kincaid, couldn't be on the call today, so you had to listen to me the whole time, but I will go ahead and turn it over to Chelsea for questions now.
Thank you so much, Lindsay. Wow, that was just a massive amount of information, and I'm sure that a lot of people are still processing it. We will take your questions, and if you don't think of them now, you see Lindsay's information up on the screen. You can always reach out to her after the webinar, or you can reply back to any of my emails. I send out all the invitations, and I'll be sending out a follow-up email as well with the slides and recording for this within the next week. So any way you can get a hold of us, we're happy to help. So first question. If you have used the Medicare lookup tool and you are excluded from participating in MIPS, can we still submit for a possible positive adjustment? Sorry, do you need me to read that again?
Nope, I think I got it. So you're basically wondering, you looked it up, you're excluded from MIPS, you didn't hit that threshold, and you want to know if you can still submit for a positive adjustment. Yep. I like where your head's at. No one likes to leave money on the table, especially if you guys are performing pretty high. Unfortunately, you can't do that voluntarily opt-in option until 2019. So if you are exempt this year, one thing I could encourage you to do, this low volume threshold of under 30,000 Medicare Part B charges or under 100 Medicare patients, that's going to stay the same whether you're reporting as an individual or a group. So if you're exempt as an individual, there's a possibility you could not be exempt as a group. So that's your first option to look at. But if you are exempt under both categories, yep, you can't actually opt in and receive a payment adjustment until 2019.
Great, thank you for that, Lindsay.
They'll still accept your data, but no payment adjustment, unfortunately.
Right. Okay, next question. Could you please repeat the examples of meeting the 70 points for the proposed 15-point performance threshold?
Sure. So I think you're referring to meeting that 15-point performance threshold, not the 70 points. For that 15-point performance threshold, some different ways to meet it. These are just different options. You could actually report all of your improvement activities. So if you're a practice, you're over 15 clinicians, you need to report either 4 medium-weighted or 2 high-weighted improvement activities to get you that 40 points. So you could just report those without any quality or advancing care information data and be above that 15-point threshold. You could also just report the advancing care information base score. That's going to give you 50% of your score in the ACI category, and then you would just need to either submit, you could do 1 medium-weighted improvement activity, or you could do 1 quality measure, and that would get you over that 15-point threshold. And then just kind of another option I mentioned is, if we remember, you need to submit 6 quality measures. You're automatically given 3 points for each quality measure as long as it meets that data completeness threshold of 50%. So if you submit 6 measures and you're meeting that data completeness, you're automatically going to be over 15 points as well.
Okay, thank you, Lindsay. It looks like that's all the questions that we have at the moment. So thank you, everybody, for joining us today. And again, please feel free to reach out to us in any way that you can. We're happy to answer your questions. We really are here to help. Lindsay, thank you for putting all this together. I know that was a lot of time and effort and a lot of information. And thank you, everybody, for joining and sticking through it with us.
Great. Yeah. Thank you, everyone, again, for being on here today.